Welcome to World Affairs Today, brought to you by the World Affairs Council, Washington, D.C., a leading forum for global education and international affairs.
Good evening. My name is Stephanie Fassler. I am the International Affairs Program Director for the World Affairs Council, Washington, D.C. On behalf of the Council, I welcome you to this evening's World Affairs Today program and Foreign Policy Panel event. This evening, we gather for a Foreign Policy Panel event called Global Threats and Lessons from the Ebola Crisis. In spring of 2014, cases of Ebola were discovered in Liberia. The virus spread to other West African countries, even with isolated cases reaching Europe and the United States. This past week, since the outbreak, we reached the estimated 5,000th death to the disease. Questions have continued to be raised as to how governments can best respond to the crisis within their borders. What support can other countries or international organizations provide to these states? Are we prepared to respond to a global pandemic and the new global world? Joining us for this evening's panel, we have Robert Sorenson, who is the Deputy Director of the Office of International Health and Biodefense in the Bureau of Oceans, Environment, and Science at the Department of State. He is currently on detail to the Ebola Coordination Unit at the U.S. Department of State. Mr. Sorenson was a Foreign Service officer for over 25 years, having served in a variety of places, including Manila, the Philippines, Moscow, Russia, and Osaka, Japan. Dr. David Morens is a senior advisor to the director of the National Institute of Allergy and Infectious Diseases at the National Institutes of Health. He is also a senior associate professor at Johns Hopkins Bloomberg School of Public Health, where he has been since 2002. He has also held professorships at the University of Hawaii in tropical medicine. He is an associate editor for emerging infectious diseases. Finally, our moderator for this evening's program is Sophie Novack, who is a staff correspondent at the National Journal, where she writes about healthcare policy, including the rollout of the Affordable Care Act, Medicaid, Medicare, health legislation, and the Ebola outbreak. Her work has been published in The Atlantic, City Lab, Defense One, and more. Please join me in welcoming this evening's panel.
Thanks to the World Affairs Council, and thanks to the panelists for being here and to all of you. Just to get started, I'm going to give just a very brief background and then turn it over to the panelists. What's been really interesting for me as a journalist kind of covering this outbreak is that I think it's very, very unlike anything that we've really ever seen before. And I'm sure that you both can speak to this kind of from a scientific and governmental perspective, but from a journalistic perspective, it's been a bit of a learning process as it goes in terms of how to kind of cover what's going on, at what point we should actually be concerned about what's happening. And so as far as the course of the epidemic goes, after the first diagnosis of an Ebola case in the United States in October, there were a lot of reports of individuals going to the hospital with Ebola-like symptoms, which is essentially the flu. And so that's been a little bit of a limbo for me personally covering this in terms of balancing at what point my job is to be writing stories that are kind of calm down everyone in the United States. This isn't something we should be worried about, and kind of balancing that with trying to direct that concern over to what's going on in West Africa, where there really is still a crisis occurring. So just to kind of frame it in that way, I thought would be useful to start just in terms of the US versus West Africa. So in the US, there have been 9 patients so far treated for Ebola. One, unfortunately, passed away, and that was Thomas Eric Duncan, who traveled here from Liberia. But as was mentioned earlier, there have been over 5,000 deaths in Liberia, Sierra Leone, and Guinea thus far in the epidemic. So that kind of shines a pretty harsh light on what's going on here versus in West Africa. And really, I think, speaks to just the difference in terms of what the healthcare infrastructure is in those two countries, how well equipped we are versus how well equipped some of these West African countries are. We've, really gotten this under control, and I think just kind of trying to direct attention over to the epidemic that is still occurring is really what's crucial at this point. Health officials have continued to repeat that really the only way that we're going to reduce the risk of Ebola in the United States to zero is by addressing that epidemic in West Africa. So I think we'll get into some of those details a bit further as we go on, but I'll turn this over now to Dr. Morens.
Okay, thank you, Sophie. Well, let me introduce myself a little more. And thank you, Stephanie, and World Affairs Council for inviting me to join you tonight. I'm here to speak about issues that are medical and public health and scientific issues. And my background is that includes having been involved in the very first Ebola epidemic when I was at CDC in 1976. And ever since then, I've worked all over the world, mostly in a research capacity, studying a number of other hemorrhagic fevers, Lassa and dengue and a bunch of other ones. And so I've seen a lot of these things before, and it always causes me to pause and reflect and think about the whole phenomenon of these emerging and hemorrhagic fevers and what they do to people and what they do to societies and how we respond to them. I'm going to just make a couple points that are perhaps you can reflect on following up on them with questions later on. But one of the things I want to say is that this is a disease that is devastating West Africa. It's not really an American problem. It's a West African problem right now. And the magnitude of the epidemic there far exceeds any problem that we've ever had here with our 9 cases. We have had one death, and that's tragic, but over 5,000 people, as has been said, have died in West Africa. So the epidemic is really over there. It's not really over here. And I think that's what we should be thinking about. And we should think of this not just as a bad epidemic, but as a human tragedy. The second thing I want to say is that these hemorrhagic fevers, which appear to be new, are there all the time. The viruses that cause these things live in the environment. They live in animals like bats or rats or mice or mosquitoes. They're always in the environment. And periodically they jump into people and they cause epidemics. And the way to think of it is what causes this to happen in every case is human behavior. So these are not a result of viral mutations or other bad things that are happening. It's a result of human behavior. There's another, can we advance the image? It doesn't seem to be working here. I will say a bit about drugs and vaccines, but I also want to make the point that this is really a public health problem. What we need far more than vaccines and drugs and diagnostic agents is just basic standard public health, the things we knew how to do 100 years ago. This is an infectious disease, and its mode of transmission is very much like things we've known how to control for a century. And so this is not necessarily the place for high-tech solutions. This takes a low-tech public health response. I'm not sure why this doesn't. I'm trying to get the images to. Well, a few more clicks. Okay, it's not working. Well, never mind. I think. Well, just to follow up on what I was saying, we think of, people probably wonder why it is that we hear mortality rates of 90% in West Africa, and yet of the 9 patients here, we've, I think, only had 1 death. And the other 8, most of them have not even been all that sick. They didn't come close to death's door. And that should cause us to pause and reflect a little bit. I think doctors who are treating Ebola in West Africa now believe, as I believe, that this is not usually a fatal disease. It's fatal in West Africa because they don't have the type of medical care that we take for granted. And most of the deaths come not from the person's body rotting and all the other things that the media portrays, but they probably die mostly of problems with hydration and electrolyte imbalance, electrolytes being the salts in the body. They mostly die from massive diarrhea in which they lose water and fluids and electrolytes. We can talk about drugs. There are drugs and vaccines in the pipeline. They're not likely to be available really quickly, although everything is being fast-tracked, and we will possibly have vaccines in the early part of the next year, 2015. But again, I think it's public health efforts that are really the key to this. So I'm going to stop saying anything and turn it over to Bob. But again, I want to make the point that this is really a human catastrophe that's happening, and we in the United States are the key people, and we have the key resources in the world to be able to address it and to be able to stop this epidemic.
Thank you. I'm Bob Sorenson from the Ebola Coordination Unit at the moment. This is, I suppose, my second or third potential outbreak, but it's much different than the others. I'm going to just talk a little bit about what we at the State Department are doing specifically, and really only about a little bit of what we're doing. I was asked to talk about international outreach. President Obama said about a month ago that we've seen great interest on the part of the international community, but haven't seen other countries step up as aggressively as they need to. This is an area where everybody has to chip in and everybody has to move quickly for us to get this under control. And I think we can say with some confidence that those remarks are already a little bit outdated, fortunately. We've done a lot of work, the State Department, the National Security Council, the President himself, calling and meeting at a very high level to engage the international community, to get them to provide the kind of resources that we're going to need to control this outbreak. We have well over $1 billion pledged by countries outside the United States, including 1 billion euros from the European Union alone. That includes the European Commission and the member countries' contribution. That has not all come through yet, but we're seeing really a good increase in international response, and we're beginning to see the UN effort get up off the ground, more slowly than anyone would have liked, but nevertheless, it's going forward in a very positive way at this point. There's still an awful lot to be done. We have recruiting and training of healthcare workers ahead of us. We need foreign medical teams, which is one distinction that the UN is careful to make. They are not really equipped yet to deal with individual volunteers. They need cohesive teams to go in and help with the epidemic. We've been working with other countries, with the UN, with all of the UN bodies, the World Health Organization, the World Food Program, UNICEF, and others, the new UN mission for emergency Ebola response, which was set up just 2 months ago, with the strong support from the UN Secretary General and President Obama. As I said, we've been calling around, video conferencing with presidents and foreign ministers and prime ministers and health ministers from their counterparts in the United States to encourage them to come through with resources, including money and including healthcare workers. I think we can say we're doing pretty well on the money with, as I noted, over $1 billion pledged. The UK is up in the $320 million range, Japan around 145, the French are similar, the Chinese also. The African Union has not been able and is not normally able to provide a lot of finances, but they are working to send medical workers from African countries to the region. The World Bank is stepping up in a very big way. I think they're over $400 million pledged for various aspects of this right now. They're working to put together an end-to-end system for the African Union and other medical workers going to the affected countries. And then we're starting to see support from the African Development Bank and the International Monetary Fund. Some of that is for post-epidemic reconstruction, for balance of payments, for a lot of things that are going to be necessary as part of this response. Some of them right now, like income support as the economies collapse and people lose jobs and food prices rise, and some of them for later to build the health systems to the point we hope, where this won't happen again, and to guard against future infectious disease threats. We've got private sector foundations coming in, 100 million from Paul Allen Foundation, 50 million from Gates, 25 million from Mark Zuckerberg, the Facebook founder. So I think there's a lot of positive news on that front, but we still have work to do on getting trained medical personnel into the region. We're building Ebola treatment units. Actually, we're pretty well staffed, I understand, in Liberia now, but we're not so well staffed in Sierra Leone. So there are all these regional differences that it's sometimes hard to keep an eye on in Washington. UN has estimated that we might need about 5,000 international healthcare workers, not all at once probably, but in rotation. The people are not going to go and spend years. I think 6 weeks or so is kind of thought of as the maximum working in an Ebola treatment unit, maybe 2 months. It's very intense. So we've been working with governments, the UN and other partners to try to recruit healthcare workers. One of the things those healthcare workers want to see, of course, is that they will themselves get treatment if they're infected with Ebola. To that end, we're setting up a medical unit in Monrovia, which opened last week. Not fully operational yet, but it's staffed by the US Public Health Service, as I believe my colleague belongs to provide a better standard of care than has been available in those countries, and to help take some of the pressure off the medical evacuation assets that we have, which are very scarce, consisting, in fact, largely of the State Department's one plane up till now, which has more or less, with a few other medical evacuations from other partners, has more or less met the demand. I don't think we've left anyone in country who was cleared to go in other respects with Ebola so far. We're working with the European Union to try to put together a more comprehensive, better medical evacuation capacity. I think the Germans are supposed to be coming online with a plane in about a few weeks. The US should be adding another plane very shortly. So we're also seeing progress in that respect. Another thing we've had to work on is this issue of the medical volunteers going home. And we've all seen that play out in the United States. We are working with other countries. Some of them reportedly have even told us they're not going to allow their own citizens to return to their own countries until they've spent a 21-day quarantine period outside their own countries. That's a very difficult thing to overcome, hard to convince people to go in those circumstances. So we've been intensively working on the kind of travel restriction and transport restrictions that we've been seeing from a number of countries since this outbreak began, really. Certainly by June, we were seeing some travel restrictions. So it's really part of our work to try to talk to the countries and explain why we need the travel and people and supplies to be able to continue to flow back and forth. That includes keeping commercial air traffic running. It's very difficult for us to do this all by charter or by military air or whatever the alternatives might be. So there seems to be some good news coming out of Liberia, but we also want to be very cautious about saying that we're anywhere near having controlled this epidemic. We're still a long way from where we need to be. We still need many more medical workers to go to the region. While there are some trends that look good, there are other places where the trends do not look good yet. And we've seen in Guinea at least twice the number of infections seem to drop and then to return again with a vengeance. We're seeing the trend going up again in Guinea right now. They've had fewer cases overall, but we're still very concerned that the assets on the ground that they need aren't there. The president said, and I think Dr. Morens addressed the question that, why do we need to stop this? And he's quite correct that it's not really a threat to the United States in the way it has sometimes been portrayed, but nevertheless, the best way to protect ourselves, as the president has said, is to stop the outbreak at its source in West Africa. I don't think anyone sees that it will become, you know, an existential threat to the United States, but it could become an ongoing endemic threat that would lead to, you know, travel restrictions and screening for every airplane and sort of constant surveillance that we really don't need, and that will also set back the West African countries even more than they have been set back already. So we can't let up the pressure. We can't even begin to relax. We need to keep getting people and assets out there. There's a lot still to do. This is the Ebola outbreak, I think, really confirms the idea that global public health can become a national security issue. It's a national security issue in that instability in West Africa is ultimately a threat to stability elsewhere, that the existence of fragile states is always a threat to the world. There are ways to address the basic security issues, including the World Health Organization international health regulations, which require countries, if they were working right, Guinea would have reported its first cases before they were even detected in actuality. They would have detected and reported them by February or January probably, and we would have been aware and been able to react much more quickly. And that's something we're going to have to work together globally on as we move forward, to detect early and respond effectively to infectious diseases that will continue to arise. So we're working on the Ebola challenge. I think we can be pretty confident that we can beat this epidemic as long as we can keep our resources flowing. But there will still be such challenges in the future, and we will still need to be prepared for them. And I think one thing I've learned in my not very many years of experience is that the next threat is always going to be a surprise. You never know what the next infectious disease that catches the attention and concern of the world public health community is going to be. I think that's a lesson that we need to bear in mind for the long term, and I'll stop there.
Great, well, thank you both. I think I'd love to just kind of start us back towards the beginning. Something that both of you mentioned is that you each have some background in these kinds of global infectious disease epidemics, but that there's something about this one in particular that seems different. And I'd love to hear from you both kind of what that difference is, kind of how we got here and what it was that happened that made this epidemic kind of explode in a way that it seems like it doesn't need to have. I guess I would start with Dr. Morens, if that's okay. You mentioned that you had previously worked on actually an Ebola epidemic, and I'd love to hear kind of what you see as differences in terms of what's going on now versus what you experienced then.
Okay, so there have been over 20 Ebola epidemics. The first Ebola epidemic that was recognized was in 1976. That's the one that I was involved in. I have no doubt that it's been going on for centuries, maybe even millennia. We just haven't recognized it. But since 1976, there's been 20 or 24 Ebola outbreaks of one sort or another. And this is by far the worst. And one of the questions is why? Well, first of all, it's worse for this reason. There are more cases and more deaths. It is being transmitted person to person by bodily fluids rather than in the early epidemics. A lot of them were centered in hospitals where there was use of contaminated needles and so on. So this is different in that there is sustained person-to-person transmission over an extraordinarily wide geographic area involving many thousands and now over 10,000 cases. We're up to around 14,000 cases detected, and the estimates are that there are actually many more than that are not reported. So this is unique in size, magnitude, and in the way it's being transmitted. I think that, and I want to say that I lived in West Africa for 2 years treating Lassa fever, another hemorrhagic fever, not Ebola, but a sort of a cousin of it, right in the same epidemic area. And I believe that one of the things that is very different about this epidemic is that it's occurring in West Africa. All the other ones occurred in Central Africa. And for those who don't know that much about Africa, you might wonder, well, what's the difference? West Africa is really culturally, in my mind at least, a very different place. There are many, many tribes. Many of the villages are multi-tribe villages. There could be 17 different ethnic groups with different languages living in the same village. They move around a lot. There's a lot of roads and footpaths. Everybody's got relatives in every other village. They go from one place to another all the time. The education and the infrastructure is almost non-existent. There's a concern about Western medicine, a reluctance to accept Western medicine. And when a frightening disease comes and the white doctors or the Western-trained doctors come to find them and isolate them, people run off into the jungle and they go to a village and they hide out with a relative, thereby spreading the epidemic. So we have a whole different socio-cultural phenomenon that's driving this epidemic that we didn't have before in Central Africa, where all the other epidemics have occurred.
I guess I would only add to that the spread of this epidemic to the big cities has made a real difference in terms of the threat to the rest of the world, because now we are in the modern world, as it were, where you can get on a plane, as Mr. Duncan did. You don't even know you're sick, and you can go to another country and you can bring it there. It, you know, as I think we've all said, it's not a threat of an epidemic to a developed country with a reasonably developed, even a not very developed country with a reasonable medical infrastructure will be able to handle Ebola. But the countries where it occurred, especially Sierra Leone and Liberia, have gone through many years of civil war. They're still in recovery. They're very low-income countries. You know, the medical system was very minimal to begin with, and that is, in addition to these cultural reasons, that's why the outbreak couldn't be stopped.
Can I just follow up on that? Because I think you made an important point about the epidemic getting into big cities. And Ebola has gotten into relatively big cities in the past, but the epicenters that we are thinking about now in West Africa, at least as far as we know, are the capital cities of those countries, which are huge. Sierra Leone has Freetown, which is over 1 million people. Conakry and Monrovia are also big cities. So that's part of it. But I think what even is worse than that with respect to our perception of risk and our concern is that it was only in 1968 that epidemics began, and that was with the influenza epidemic in 1968, that epidemics became transmissible by air routes. Before that, in 1957, the influenza pandemic was transferred around the world on ships. Starting in 1968, we began to see epidemics transmitted from air hub to air hub. And air hubs are generally huge cities with lots and lots of people. So now, because the world is, the global world is urbanizing, we have urban, crowded concentrations of people and airlines that take infected passengers between them. So we had the 1968 flu pandemic that spread that way. We had one called acute hemorrhagic conjunctivitis in 1981. We had SARS 11 years ago, if you remember. That started in China and spread by air routes to Hong Kong and then elsewhere, including Canada. So this is a whole new phenomenon associated with rapid and intensive travel from major air hub to major air hub. And anything that's happening in any other city can be here in less than a day.
And I think that the kind of cultural difference is a really interesting point, just as far as my own kind of reporting and reading. I think that's also kind of an interesting distinction to draw between the kind of panic that we're seeing in the US versus the kind of panic that we're seeing in West Africa. And it's in both cases kind of an issue of a lot of misunderstanding about the virus, but in very different ways. I think another point that I'd love to touch on is that was also mentioned is we have been getting a bit of good news recently, both in the US and from West Africa. The US being that Dr. Spencer has been cured, leaving no Ebola patients currently in the United States. There are, of course, a number still being monitored all over the country, but no one has been diagnosed at this point. And then from Liberia, that this idea that these cases are going down. I'd love to hear from both of you kind of how much optimism should we really have about this. It seems to me that there's a pretty big risk in kind of being too optimistic about the situation. And I'd love to hear from each of you kind of what we can make of this news and what kind of the risks are still.
I feel like I'm commenting on medical matters some of the time, but nevertheless, I'm quoting or citing Dr. David Nabarro, who's the special envoy for Ebola. The data just really aren't very good. And even if the data we were working with this good news were good, it wouldn't be enough to really draw any, terribly optimistic conclusions right yet. We have sketched out, the United Nations and the United States and the World Health Organization have sketched out what's needed. We're still working on that together, but we aren't really that close to having everything in place that we need to stop this epidemic. So while yes, we can be encouraged to some extent by an apparent drop in the number of new cases, we are far from being out of the woods. There are other places, that's not even all of Liberia. Parts of Liberia, we still have cases increasing. In Guinea as a whole, we have cases increasing. In parts of Sierra Leone, we're seeing new outbreaks. I don't know the counties and numbers all that well, but it's, we're very far from being able to say we've got this thing beat. And we need to, I think we can be optimistic in the longer term, but we really need to keep sending resources and making sure. It's going to be a long time. I don't want to give any time estimates, but it's going to be quite some time before we see the last human case in this epidemic. And there's going to be a lot of resources needed, and then I think what we need to avoid is something that's happened in the past, where we have a massive emergency response, and then we kind of go away and leave people without much better or with not any better infrastructure than they had in the beginning. So there's a long way to go, and encouraging numbers are encouraging, but we should take them with several grains of salt.
And I would agree with everything you said, I think I would not say the epidemic is going away. Yes, cases are decreasing in Monrovia and some other places, but I believe every single county or administrative district in both Sierra Leone and Monrovia and Liberia have now or have had cases. It's basically all over those two countries and over most of Guinea. And we don't know what's happening out in the villages. The way to think about West Africa is that each country has a big port city, a big, incredibly impoverished urban center. And right outside the city limits, you're in the heart of darkness. There's a village life that goes on like it has gone on for thousands and thousands of years, with very little what we would call modernization, with people living a subsistence existence, barely scraping by, with no infrastructure. And we have a limited ability to know what's happening outside those big cities. It's relatively easy to set up, that's not easy, but it's relatively easier to set up a bit of an overlaid public health structure in the capital cities. But if cases are continuing to occur out in the periphery, the reach out into the periphery is just not there yet. So I think I'm not yet optimistic. I do agree that I think this can and will be controlled, but I'm not sure how quickly it's going to happen. I see that it will hopefully slow down, but maybe slow down at a very, very low rate. That is very, very slowly. And I think we, the Western nations, particularly the United States, need to do a lot more. Not to fault anybody or to engage in a blame game, but the resources that are needed in West Africa right now are far, far beyond what anybody has been able to provide. And that's just because this is so unprecedented. This has never happened before. Something that is this overwhelming over such a large geographic area in a completely resource-poor, enormous expanse of Africa. What do you do? Somebody, several months ago, a person working for the State Department, not an official person, but a person just asked me as a private citizen, what do you think we need most in Africa? And this is probably in June. And she said, more doctors, more nurses, more medicines. And I said, no, we need the United States Army. By that I meant, what I went on to say is, these are places with no infrastructure. We need somebody to come in from the outside and give them the infrastructure. That means transportation, communication, equipment that disinfects water, so that you have water that can be used for sterile purposes in a hospital, and transport of people and of supplies and reagent, diesel generators to provide electricity. There are hospitals in Africa that don't have electricity. Many of them still have dirt floors. That's how resource poor it is. We can't, no matter how many doctors and nurses we send into West Africa, they're not going to be able to do the job they need to do unless somebody goes in and creates the infrastructure there. So I think this is a huge challenge, and we were talking before this session a couple of days ago that I said, and I think others maybe agreed with me, I'll let Bob comment on himself, on his own, is that I think one of the lessons that will come out of this after all is said and done, and we are doing our postmortems on the epidemic and our response to it, is that we really need to think about having an international, global firefighting response for things like this that will surely happen again. We really dodged a bullet with SARS. That could have become a global pandemic that killed tens or hundreds of millions even. It could have, in theory. It didn't happen. But we weren't prepared to stop it. It was just luck, I think, and very good public health in Hong Kong, Canada, and other places that curtailed that. Now we have this Ebola epidemic, and this is not going to become a pandemic either, I don't think, around the world. But we have to ask about what's going to happen next time. What if Ebola was just a little worse than it is now and was able to spread in other parts of the world? What if SARS had been a little worse than it was 11 years ago? We don't have any way to respond to that. And I think this is a wake-up call that tells us that we as a global community need to rethink having some kind of massive firefighting force that can be deployed quickly and massively to put out the fire before what's happened over the last few months has happened.
Well, that's right. We're beginning to think about that. I don't think anyone I have not seen any comprehensive or coherent proposal yet about how to do that. No. But we are beginning to think about that.
And what I've kind of seen in that regard is the White House requesting this new request of about $6.2 billion from Congress. And I know part of that is intended to go towards this kind of global security network that intends to be built. But it seems to me, correct me if I'm wrong, like that's a little bit ahead of where we are now. Right now, there's kind of this issue that we need to take care of in front of us.
Well, I'd say two things about that. The Global Health Security Agenda was put in place, was planned, was discussed on a pretty good interagency basis, including the health agencies and the State Department and the Defense Department and the Agricultural Department and et cetera, well before the Ebola became an issue this year. But it does fit very well with a lot of what we've seen happen. It's meant to provide an early warning system, an early response system. It's meant to build that within countries and within regions so that every country will at least have the basic capability to prevent insofar as possible, to detect early, and to respond effectively to infectious disease outbreaks. What I think we probably do need is to think about the International Response Corps, or whatever we're going to call it, in addition to that. So that the Global Health Security Agenda does move in the right direction and will be a contribution for the future, but I don't know that we can say right now that it's certainly not everything we need to do in the affected countries and for global public health. It was never meant to be everything we need to do. It was meant to capture the kind of the nexus between national security and health security, to use some of the same systems that were put in place to deal with threats like bioterrorism, and to make sure that those systems can also deal with infectious disease threats. And as I said, to build capacity within countries. I think that there's a long way to go there too, but there's a lot of commitment to moving forward on that, and it will be helpful for the future. Let
me just comment on that. I agree. I think that, and I want to add that one of one of the things we're seeing in this Ebola epidemic is that there's an issue of scale up. There's an issue of the epidemic will go as fast as it wants to go, and nothing we can say about it will slow it down. We have to be able to scale up, and we've never had to scale up so massively, so quickly. We, science and public health globally, doesn't know how to do that. I think the United States has been the key player in this in West Africa. And other countries have too, Britain and Germany and France and a number of other countries, but it's primarily the United States because the resources needed are so overwhelming in terms of trained people, in terms of money, that our leadership is really needed. But I think that the United States can't do it alone. We have to work to get some kind of I don't have any specific idea, but I think we should be working towards eventually having some kind of what I call a international epidemic firefighting capacity, so that when things like this happen again, not only can we respond, but the scale up has to be really quick. It can't be measured in months and years. It's got to be done very quickly. We have to have that kind of capacity. And as Bob said, I haven't heard anybody yet discussing these kind of ideas in specifics, but I think it's worth raising the issue at the earliest possible time so we can all start thinking about it.
And is that something that you both kind of see other countries jumping on board with? It seems like there's still a lot of countries that could be contributing more than they are currently in this epidemic. And I wonder if that's kind of any indicator moving forward, or you think that there is kind of this larger sense that really is critical and that there will be more countries jumping on board on that kind of a project.
I can tell you that the United Nations and the United States and some of the other kind of traditional donor countries like the UK and the Nordic countries and some others have begun to think about this, and that's about all I can say on that.
Yeah, politics is not my field, and having worked with WHO and many other international agencies, I've never been overwhelmed by the speed at which they could come together and derive a consensus and get something done. We have to remember that WHO is not a well-funded agency, and it doesn't have a lot. It's sort of an organizational oversight and coordination agency. It doesn't have tens of thousands of people sitting around ready to be deployed to an epidemic. It's in this sense, it's coordinating. We need maybe something that's different, and we need to be able to use the resources of the countries that have the resources, because WHO itself will never have those resources. It's a challenging thing to think about. I think that, I just want to add, from my sense is, from what I read in the press and in documents that I see that might not be out in the public domain, that the entities that are most likely to be behind this idea are the West African countries themselves, who are completely overwhelmed and essentially desperate. And the message to us, the United States and the West, again and again on drugs and vaccines and supplies and personnel is, please give us more and sooner. I don't think they're going to balk at all, because they realize that they need help. And if we don't help them, they're going to be unable to help themselves.
Well, President Obama was on board with that message at least a couple of months ago. He was saying it's not enough, it's not fast enough, fairly frequently, I believe. And I think
yes.
We are doing better, but it's probably still true that it's not enough and not fast enough.
And it's an interesting issue, kind of the idea of not necessarily other players wanting to jump on board and wanting to get involved, but just kind of the issue of who is ultimately coordinating these kinds of efforts. And I was looking into this a while back, I think around August, when this was more coming into the attention of the American public. And that was something that kind of occurred to me, is who is ultimately in charge here? And I was speaking to a number of individuals at all different organizations, and most of them were saying ultimately it's the UN, ultimately it's the World Health Organization. And I talked to the World Health Organization, and they said, well, ultimately, it's these African nations. I was kind of like, well, hang on a second. Clearly, there's no one ultimately in charge if they're saying different things. So I'm curious kind of and I know that since then, the World Health Organization has said that, there were some mistakes made and things could have been, actions could have been taken more quickly, but I'm kind of wondering, ultimately, what kind of changes can we feasibly expect to come from this? What kind of lessons can really be learned from what happened here as far as just kind of that global network in addressing these kinds of conflicts, and what kind of change can we kind of reasonably expect to come out of this?
I'm not sure of the answer to that. I think we'll see some attempts to look at the World Health Organization and how to improve its effectiveness. I don't think anyone is really envisioning it as this international fire brigade per se. I think we've seen once again that the United States leadership is essential. I think it, it would be wonderful if the World Health Organization could have taken charge, as we kind of asked them to at the beginning, taken charge and controlled this, but it didn't work out for various reasons. Not the least of which is the scale, but part of which has been some slowness on the part of the World Health Organization. But where we're ultimately going is something I really can't speculate on at this point.
Yeah, it's hard to imagine, really. None of us has a crystal ball. I think, there is no one entity, be it WHO or the United States or a national government in Africa, there is no one entity that will ever have all the resources and capacity of the entities that exist right now to take charge. I would say that, in my way of thinking, WHO is in charge of this, but they're in charge only in the sense of information, communication, and organization of efforts. But they don't own all the parts, and WHO doesn't own the part. WHO brings in resources from countries, and WHO is funded largely by a few wealthy nations, the United States, Japan, and a small number of wealthy nations, but virtually every country is a member. And there's a certain politics that goes on. When you're in WHO, you have to please everybody. And WHO really doesn't have, WHO has an administrative staff, but it doesn't really have frontline people who, it has very few people who investigate epidemics. It has very few and almost no doctors who treat patients or military people who provide infrastructure. I think those are going to have to come from the resources that are drawn together centrally from where they exist. But I've said it before, and Bob just said it too, and I don't say this because I'm an American and proud of my country, which I am, but the only player that has almost all the resources in the international scene right now is the United States. There are some European countries that have substantial resources, and maybe Japan and some other countries, but it's the United States by far and away the most comprehensive resources in hand that could be applied to this epidemic are our resources, and we are moving, I think, as quickly as we've ever moved in the past to apply those resources.
Great.
I would only add to that the European Union has a lot of resources, but they're split up among member countries to a great extent. Mm-hmm. The European Commission and the European Union have really been doing an excellent job of responding within the limitations. They don't have the same kind of unity of command that we have as the United States, but they have, I think we can say that the European Union and it's certainly its largest member countries are very much concerned about this and are really stepping up now. Some of them we might say have been a little slow, but they really are stepping up with resources and trying to contribute within their ability to this response. And it's a lot. They do have the resources, they just don't quite have the mechanisms that we have to deploy them quickly.
Thank you. I think we'll take questions from the audience.
Good evening. Thank you for being here. I have a two-part question. My name is Ike Puzan. I work for Pixera Global, which is an NGO that works with businesses to engage throughout the world. My two-part question is, how do you see, or do you see that more need of the private sector, not the money piece, because it sounds like you got the money piece flowing, if I understand it correctly, but how can businesses also engage in attacking this problem? That's the first question. And the second part of the question is, are you absolutely sure that we have it under control, or our hospitals here in the U.S. and these cities are prepared for the second Duncan-type person who flies in? Now, I know we've taken some steps to improve, but I'm just wondering if you're absolutely sure that we have it throughout the United States and the cities. Thank you.
I'll just briefly talk about the private sector engagement, which is something that we have been doing that I didn't mention, but we've got a lot of dialogue going on with organizations like the U.S. Africa Business Council, I think that's what it's called, and other kind of interested organizations. Even Monday, I believe, there was a conference call with NASDAQ companies were invited to listen to some briefing on what is going on with the Ebola epidemic and what they can do to help. So we've been engaged in a pretty intensive dialogue with the business community. Some of the things that we're asking for and that are coming through to some extent are kind of obvious, things like trucks and better mobile phone coverage and supplies. But we're also very much interested in working with businesses to try to improve the infrastructure, as we move forward. Everybody's impressed with Coca-Cola's ability to move Coca-Cola to the remotest villages anywhere, and we'd like to learn from their experience as well as get their help in terms of getting to some of these remote areas. So there's a lot of engagement continuing with the business community, and I'm not deep into the details on that, but it's certainly something we're taking seriously and want to continue.
And I apologize, just to add something onto that, something that I thought was interesting, just a couple days ago, both Facebook and Google got involved in this. Both are including kind of a banner notification on top of the page where individuals can click to donate, and that money will go to specified aid organizations. But correct me if I'm wrong, but I think part of Facebook's plan as well was to also work on establishing internet in some of these areas to presumably kind of help coordination and communication among different groups that are working there. I thought that was an interesting way that businesses were getting involved as well.
I want to add something to what Bob said. I was sort of amused when he mentioned Coca-Cola because it reminded me of something. When I lived in Sierra Leone in the late 1970s, I was working really out in the jungle, and many times I went into places where nobody had ever seen a white man, and the little kids would start screaming "Pumui" when I would be coming into a village on a footpath. But even in these remote places in the 1970s, everywhere I went, into villages where they'd never seen a white person, they had Coca-Cola. And they even had signs. One of the African signs says, "Everything goes better with big, big Coke." Big words. Everything has to be big in Africa. I also saw out in these remote villages, I also saw somebody wearing a T-shirt from Peaches Records and Tapes, which was one of the big stores in Atlanta where people used to give T-shirts and everything to the Salvation Army, and they'd end up in these villages. So, NGOs and businesses, really, some of them at least, have an incredible reach. And I'm not a businessman, so I can't answer that aspect of your question, but I think there must be an important role. With respect to the second part of your question about are we absolutely certain that we've got this under control, I never try to be absolutely certain about anything. But I think it's worth saying that, remembering that if you remember a few weeks ago, when the first cases came into Dallas, and Dr. Tom Frieden, the director of CDC, made some comments to the press like, well, this isn't a problem, every hospital knows how to deal with this. And he was roundly criticized for that and had to retract his statement and downplay it or something. But in fact, what he said was hypothetically true, that there's nothing magical about how this disease is transmitted. It's transmitted in the same way that bacteria are transmitted in hospitals, and the doctors and nurses have been trained for almost a century to prevent. What's different is that this is a deadly disease, and the thing that nobody says is that although doctors and nurses know how to wash their hands and wear gowns and gloves, they get busy and they have breaks in procedure. And when Dr. Frieden said that there must have been a break in procedure in the hospital in Dallas, that's what happened. But the reality is, and he didn't perhaps go further, the reality is in hospitals all over the country, all the time, there are breaks in procedure because crisis, emergency rooms, people come in a crisis situation. Doctors and nurses are human beings working at an incredible pace under pressure. So, am I absolutely sure we have this under control? In theory, yes. But if more cases come in, it's very possible there will be more accidental breaks in procedure for whatever the set of circumstances. And it's very possible we could see more cases. But we won't see, I don't think, sustained transmission. We won't see epidemics being seeded in the United States. We'll see individual 1 or 2 or at most a few hospital cases that occur uncommonly under unusual circumstances.
My question is about prevention and building local capacity. I'm Maria Nelly Pavicic from the Rotary Club of Washington, D.C., and we cooperate with the Rotarians in Liberia to support immediate needs. So the complaint we get from them is that the local capacity, perhaps in the community health workers, needs care. So my question is if you know of an organization who is doing that work. We know about the health workers, doctors and nurses, and working there, but we don't know anything about that effort. So in the long term, the own country will know how to prevent, as you described in one of your slides, prevention mechanisms will be in place.
It's been many years since I've lived in West Africa and worked there, and things may have changed, but my impression is the root problem is that in most of these countries outside the big cities, there just is no infrastructure for anything. There's nothing. There's just people living in mud huts with virtually no possessions, no running water, no electricity, nobody with an education. If you can get girls to go to school through the 3rd grade, that's considered tremendous progress. Multiple languages in many of the villages. I think there's very little public health. Some of the villages or some of the areas will have a district clinic for tuberculosis or for leprosy or something like that. But there's just not a public health infrastructure. At least there wasn't when I was there. And remember that 2 of those countries have had terrible civil wars in recent decades. Sierra Leone and Liberia have had related, independent but related civil wars, which destroyed much of the country and whatever infrastructure was there. So I think the problem is you can't have public health in a place where there's no infrastructure of any kind.
Great. Well, thank you guys. Thank you everyone so much for coming. Thank you to the World Affairs Council and to the panelists.
Thank you.
I believe there's a reception outside if everyone would like to join. Thank you all very much.
Thank you, Sophie.
Thank you for joining us for World Affairs Today, a production of the World Affairs Council, Washington, D.C. Stay connected with us at www.worldaffairstoday.org.